Good evening, everyone. My name is Dr. Chinmayanand, and you are watching my channel Earthly Existence. And today I am with high yield MCQ for medicine subject, since this subject is very difficult to revise. So, by this method of smart course, you can revise most of your topics and most of your subtopics too. Before that, I want to request all of you to follow me on my Instagram. My ID is here, as well as you can subscribe my YouTube channel also. So let's move on to the first question. And first question for today is: a patient came with fatigue, anemia, hyperpigmentation of knuckles, oral mucosa, palm and hands, and tachycardia with BP of 79/60 mmHg. Sodium is 130 milliequivalent. And what is the diagnosis? So this is pretty simple case, we know that, but before that we should know the differentiation between these three topics, that is Conn's, primary adrenal insufficiency, and Cushing's. Vitamin B12 deficiency is totally different topic. So let's come to the discussion of Addison's disease, that is primary adrenal insufficiency. So in Addison's disease, what happens is that excess of ACTH occurs, and that will lead to different symptoms. So it's firstly, Addison's disease is autoimmune destruction. Here in Addison's there is autoimmune destruction. Second, there will be abdominal pain, nausea, vomiting. ACTH stimulation test we will be doing here, and low cortisol will be coming. So stress, so A for ACTH excess, autoimmune destruction, abdominal pain, ACTH stimulation test. Then D for dark skin, hyperpigmentation will be there due to increased melanocyte stimulating hormone. Then salt cravings will be there. Apart from that, sodium will be low, that is hyponatremia, and hyperkalemia will be there. Orthostatic hypotension will be there. Feed me salty sausage. In this, a patient crave for salt. That's the reason patient try to eat very salty things. So weight loss will be there, easy fatigability and weakness. Most common presentation with hyponatremia and hyperpigmentation as per our this clinical case. So here answer will be primary adrenal insufficiency for sure, but we have to differentiate everything. So adrenal insufficiency, so let's discuss it. So primary and secondary. Primary problem will be localized into the adrenal gland, can develop either acutely or chronically. Chronic form known as Addison's disease. Secondary, in secondary disease there is a pituitary problem. So pituitary gland doesn't secrete or doesn't stimulate adrenal enough to ensure adequate cortisol production. So that's why cortisol production will be affected here in this case. So we can differentiate like this. This table is very important to solve MCQs very fast. So first, that is primary adrenal insufficiency. In this case, ACTH will increase, and in secondary, the ACTH will decrease, since here will be the pituitary problem. So other than this, in secondary, aldosterone, serum potassium will be normal, and serum sodium will be low. Aldosterone in primary will be low, as well as serum potassium will be high, and serum sodium will be low. So this table you have to learn, and this is pretty simple if you keep everything in mind like this. So it will be easy to solve. Then question. Then mineralocorticoid deficiency, salt craving, postural hypotension, hyperpigmentation, vitiligo. This will happen only in primary adrenal insufficiency, not in secondary. So while answering, you have to be clear that most of the things happen in primary adrenal insufficiency. Next, coming to diagnosis of adrenal insufficiency, by doing the serum morning checking, serum cortisol we can check, and by this algorithm you have to keep in mind, you should read. Then treatment of primary and secondary adrenal insufficiency. Primary will be treated by hydrocortisone plus fludrocortisone, and secondary by hydrocortisone itself. So corticosteroids, again, these are very important in this treatment. Now coming to the Cushing syndrome, the differential diagnosis. In normally what happens, cortisol gets converted into cortisone by the help of 11 beta hydroxy steroid dehydrogenase enzyme 2. But in this, there will be an enzyme defect, and that will lead to excess cortisol, and that will produce symptoms. So what happens, normally there is cortisol has glucose corticoid and mineralocorticoid effect, but cortisone has only glucocorticoid effect. So here mineralocorticoid effect, which is harmful for us, doesn't generate. But when this cortisol accumulates, this mineralocorticoid effect is very important, and like it's major thing that produce symptoms, different symptoms. For example, in this case, symptoms of Cushing syndrome will be moon faces will be there, buffalo hump, muscle wasting, and thin extremities due to catabolism. Catabolism increases due to cortisol on protein attacks. Then stretch marks, weight gain, and obesity will be there. So then easy bruisability will be there, and skin tone and skin and bone thinning will be there. Apart from that, in males, libido will be decreased, and female menstrual cycle changes will happen, and hirsutism will also be seen. On the background, what will the background of the disease? Set of symptoms resulting from exposure to increased level of cortisol, aka hypercortisolism, as we have discussed here. So simple, this is the major principle. Then apart from that, causes in this long-term use of glucocorticosteroid medication can result in this Cushing syndrome. Then pituitary tumor in Cushing's disease, as well as ectopic ACTH production tumor. Ectopic tumor can be there, adrenal tumor. Diagnosis, medical history, physical examination, lab test. So major lab test is 24-hour urinary free cortisol test. We have to do late night salivary cortisol and low or high dose dexamethasone test. These are low or high dose dexamethasone test. So low dose LDD, MT, or high dose. Then imaging can be done. So this is very important. Apart from this will be endogenous or exogenous source. There will be exogenous or endogenous source for cortisol. Apart from that, next is Conn syndrome. Conn syndrome causes aldosterone producing adenomas, bilateral adrenal hyperplasia will be there. So symptoms of Conn syndrome will be uncontrollable increase in blood pressure, excessive thirst, increased urinary frequency, increased nocturia, muscle cramp, weakness or tingling, dizziness, blurred vision, and headaches. So symptoms will produce very differently. So it's easy to differentiate Conn's from Cushing's and primary adrenal insufficiency, but difficulty in identifying Cushing's versus this primary adrenal insufficiency. So aldosterone, background of this Conn's syndrome will be increased aldosterone secretion with normal renin level. It is called as primary hyperaldosteronism. Serious long-term impact will be high blood pressure. So high blood pressure, since water retention will be there, and that will cause high blood pressure due to hypernatremia. So that's the question, guys. This question very important, recently asked in NEET PG. Next, a patient present with perioral pigmentation, BP of 90-60, sodium is less, so hyponatremia. Then hyperkalemia is the increased potassium. And what is the most appropriate treatment? So same, previously we discussed all these conditions, so we can apply here. So what will be the answer? Will be hydrocortisone plus fludrocortisone. Pigmentation is the perioral, it can happen in ACTH, that's primary adrenal insufficiency. So this is the answer. Next, which of the following is correct about pheochromocytoma? Pheochromocytoma is very important, and it's oftenly asked. So let's see which is the correct. So before this, 90% there is a bilaterality. Let's see, before solving this question, you should know this table. This is MEN1, MEN2, and MEN2B. In MEN1, pituitary adenoma. In MEN1, where we can see MEN1 syndrome, that is pituitary adenoma. In MEN1, we see pituitary adenoma, parathyroid hyperplasia, pancreatic tumors. In MEN2, parathyroid hyperplasia, medullary thyroid carcinoma, and pheochromocytoma. Apart from that, MEN2B is all about M. So mucosal neuromas, marfanoid body hepatitis, medullary thyroid carcinoma, and pheochromocytoma is seen here. Now, so correct, we have to find correct. So now coming to the question, correct about pheochromocytoma associated with MEN2A. So MEN2A and MEN2B. So this is pretty direct. Remaining things are not perfect in this case. So while solving this one-liner type of questions, you should know accuracy is very important. So this table is very important. Now coming to this question, a female present with chorioethioid moments, dysarthria, dystonia with image finding, that is this, I guess this is the KF ring, Kaiser-Fleischer ring. Which of the following is the best investigation to confirm the same? So best investigation to confirm, most of the time we tend to mark serum ceruloplasmin, but it is not. Most, when they ask best investigation, then it's a hepatic parenchymal copper estimation. This is asked a lot of time, and this is a recent question in NEET PG 2024. So what happens in this condition? We are looking at this condition of Wilson's disease we are dealing with. So in this, Kaiser-Fleischer ring is seen. Apart from that, there will be symptoms. Symptoms like adult coarse proximal wing beating and chest beating or tremor will be there. Masked faces will be there like this. Apart from that, adolescent, it most commonly happen in adolescents, more likely have generalized dystonia and neck and face grimacing will be there. So face grimacing as well as improper movements will be there. That is, we have choreothoid movements, dysarthria will be there, and dystonia, muscle problems will be there. So there will be degeneration changes, lenticular nucleus degenerative changes will be there. Apart from that, this is post-necrotic type of cirrhosis can be seen. So in this case, the major thing is we have to take a biopsy here. So hepatic tissue copper measurement by biopsy, at least 1 centimeter in length we have to take. So parenchymal copper concentration is measured by neutron activation analysis or atomic absorption spectrometry, gold standard for this. So this is a pretty simple question, we know, but while dealing with Wilson's, there is one more question, one more thing comes in mind, that is iron deposition. That is, these both conditions are inherited autosomal recessive disorder that can cause cirrhosis and organ toxicity due to excess metals. So in case of hemochromatosis, the main gene involved is HFE gene mutation. Apart from that, intestine absorbs excess of iron which is received by liver. Then bronze diabetes occur here. So probably the all intestine problem occur here. Then we treatment for this, we do phlebotomy, and arthritis will be present in hemochromatosis. Then Wilson's disease. In Wilson's disease, there is CNS problem, as we have seen. Renal disease will be there, that will lead to hemolytic anemia. Kaiser-Fleischer ring we have seen. Liver cell ability to excrete copper into bile is impaired here. So this is, you can remember by this. Then ATP7B gene mutation is here. So while on the exam day, what happens, we get confused in these genes. So these are very, very important. One liners can be asked, as well as sometimes clinical cases given, you have to find the gene. So for iron, Fe iron, and ATP-B7 gene, because there is ATP7A another that's seen in another one. So let's move on to the next. A mother brought her 2-year-old child to the OPD with complaint of lack of weight gain, abdominal pain on eating, and poor eating habits. The child was advised gluten-free diet. So gluten-free diet is a strict lecture which there was improvement in the general condition and weight gain. What is probable diagnosis? So simple gluten-free diet. So it's showing like celiac problem will be there, like celiac disease. So we should discuss this disease. So celiac disease, that's celiac spray or gluten sensitive enteropathy, immune mediated response to gluten, a protein in wheat, barley, and rye. So gliadin, that is anti-gliadin antibodies will be there against gliadin, and tissue transglutaminase. So you should remember these antibodies names. Malabsorption of vitamin, minerals, and other nutrient takes place after 6 months when caregiver introduced gluten. Okay, now symptoms. Celiac disease and gluten sensitivity has little bit of differences. You have to learn this for your future purpose. Like, let's just go through it, but no need to go in too much detail, so that on the day of examination we may tend to do this question wrong. So this is for just information purpose, but this thing is very important. One MCQ is always asked. During my time also this MCQ was asked regarding antibodies. Then a patient presented with abdominal pain, hepatosplenomegaly, WBC greater than 50,000 per millimeter cube. Then which of the following gene is involved? So WBC increased, so probably it and hepatomegaly, abdominal pain. So patient here, they must have a given age, if age should have been given, but 50,000, this is leukemia. So leukemia, in case of leukemia, that is ALL, Philadelphia chromosome occurs. So here plus the question is incomplete. In this, they should have be given age less than 15 years at least, with few more symptoms that will give us like hint towards this answer. That is Philadelphia chromosome, that is T9:22. So before that, characteristic of leukemia you should know. So while solving this leukemia question, you should know how to differentiate them. ALL is basically a lot of time asked, and age is major, less than 15 years. Then AML, majority adult leukemia. CLL and CML, when C comes, then greater than 50 years of age, CLL and CML. Then classification of ALL is, we have B cell ALL and T cell ALL. In AML, we have promyelocytic, acute monocytic, and megakaryocyte. CLL also has B and T type. Then CML, chronic accelerated blast. Chronic accelerated and blast stages are there. Apart from that, primary WBC affected. We know these are the particular WBCs affected in each of them. Then lab results, very important. Lymphocytes increase here in bone marrow. Then increase in circulating lymphocyte and lymphoblast. Decrease circulating RBC, platelet, mature neutrophil. So more hints could have been given in this question, so you have to learn this. Then increase myeloblast, circulating and bone marrow. Decrease RBC, platelet, mature. This everyone has the same thing, but only one thing that is uncommon, that is circulating lymphocytes, here myeloblasts and here lymphoblasts. Then CML also shows these. So in chronic in chronic stage, increased granulocyte, increased thrombocyte, 10% blast. Accelerated stage, they show increased blast, basophils, or increased or decreased thrombocytes. So this ratio have been done by you. Then cellular characteristic. Cellular characteristic in ALL is basic cell type is T cell ALL, starry sky in bone marrow. This is very important because questions are asked a lot of time in this. Then clinical features, T cell ALL, that is mediastinal mass will be there, and risk factor in ALL, Down syndrome, as well as AML, Down syndrome. Then Philadelphia chromosome is particular for CML, but in case of ALL, there can be Philadelphia chromosome positive. So in ALL, that is, we have learned this stuff from here. And remaining rods in myeloblasts, AML. Then smudge cells in peripheral, that is CLL. Then pseudo-Gaucher cells in marrow in CML. So this table is very important. MCQs will be asked here. Now this question is very important, that is acid-base balance. So 50-year-old patient presented with fatigue and weakness. Some relative history was given with pH of 7.3 pH. Then bicarbonate is 6.3, 16 mmHg. Then sodium is 135, and potassium 4.5, and chloride 113.5. So lactate was normal. Which of the following optional correctly describe this condition? So before this, you should revise this content. That is acid-base balance normal value, pH 7.35 to 7.45, it's normal. Then below this will be acidosis, above this will be alkalosis. Then optimal value is 7.4. Then bicarbonate is 22 to 28 milliequivalent, is normal value. Then this is for carbon dioxide, that is 35 to 45 mmHg, and N gap normal is 6 to 12 milliequivalent per liter. Below this is low N gap, and above this will be high N gap. So optimal value is less than 10, and here are the respective optimal value. You should learn these values. And now coming to the chart, so how to solve this type of question? Very easy. pH 7.3, below this acidosis, above this alkalosis. So a primary change in bicarbonate, when bicarbonate change is termed as metabolic. If change in bicarbonate is in keeping with pH, that is, if there is acidosis and bicarbonate is decreased, the problem is metabolic. So when there is acidosis, and bicarbonate is decreased, then it's a metabolic. So coming to the question here, pH is less, so it's acidosis, and bicarbonate is also decreased, so it is metabolic acidosis. So for now, we'll metabolic acidosis. Let's see, coming to another now, like if change in bicarbonate is opposite, that with pH, that is if acidosis and bicarbonate is increased opposite, then problem is compensatory metabolic. So this case is not fulfilled here, so this is our case. Then primary change in carbon dioxide is termed as respiratory. So if change in carbon dioxide keeping in line with pH, that is if in acidosis carbon dioxide is raised, the problem is termed as respiratory. If change in carbon dioxide, that is if there are acidosis and carbon dioxide decrease or normal, the problem is compensatory respiratory. So here carbon dioxide is decreased and acidosis, so decrease, it's a compensatory respiratory with anion gap. Now coming to the anion gap. So what is anion gap? So anion gap, we know basic formula of anion gap is this. Calculate anion gap. So sodium minus bicarbonate minus chloride. So sodium here is 135 minus bicarbonate, that is 6.3 minus 113.5. So it will come around 15. So 15, now 15, and coming to this table, it is high, so it's high anion gap. So it is high anion gap metabolic. So it is metabolic acidosis with partial compensated respiratory alkalosis with high anion gap. So very important question, and it's easiest way to do this is by this, so you can learn remaining things. Now this is a condition, these conditions are very important to learn. So we have high anion gap metabolic acids, we have methanol, uremia, diabetic ketoacidosis, then paraldehyde, then iron tablet, INH, lactic acidosis, ethylene glycol, salicylate. So acidosis word is the, in that case you can learn high anion gap acidosis. In normal case we have this fistula, pancreatic, uretrosigmoidotomy, small bowel fistula, extra chloride, diarrhea, then carbonic anhydrase, Addison's disease, and renal tubular acidosis. This is very important. So now coming to this question, a patient came to the emergency department with dyspnea and palpitation. He is known case of CKD. The following ECG is, what's the diagnosis? In this case, you can read the question reversely also, since ECG is given. So what's the diagnosis in ECG? So in ECG, we see tented T waves. So it will be hyperkalemia for sure. So you should know this. So tall P, peaked T waves. This is wide QRS interval, wide or flat P wave, and prolonged PR interval. So this is hyperkalemia. On contrary, hypokalemia, there is prolonged U wave, that is T wave inverts pull and push effect of potassium on T wave ECG. So this is hyperkalemia. Now, which of the following cannot help in differentiating psoriatic arthritis and other form of arthritis? So for this, you should learn the differences between these two arthritis or arthropathy, whatever we say. Osteoarthritis, that is stiffness with activity, sclerosis, bone spur, joint space narrowing. This is the major history clincher for it. Then we have psoriatic arthritis. There will be asymmetrical. There will be psoriasis, that is nail dystrophy, sacroiliitis, ankylosis, dactylitis, and enthesitis. Rheumatoid arthritis, symmetric. It's symmetric. Peripheral disease, bone erosion, and proximal involvement and district lesion. So this table is very important. Psoriatic arthritis and rheumatoid arthritis. Psoriasis, in case of psoriasis, symmetric, asymmetric, enthesopathy, dactylitis, nail dystrophy, HIV association. Everything is positive in psoriatic arthritis. Rheumatoid arthritis, we find two things positive. Those are, it's symmetric more than asymmetrical one, and remaining things are absent. So it's very easy to differentiate these two conditions. You have to learn this table. So in this case, what will be? Dactylitis is seen in psoriatic arthritis, enthesitis, nail pitting, presence of diarrhea. So it is, these three are seen. So learn this. Now coming, which of the following isn't a component of meant to be? Previously we have done again meant to be all M's. Mucosal neuroma, so all M's. So medullary thyroid carcinoma, orphaned hepatitis, yes. Mucosal ganglioneuromatosis, yes, but there is not para. So what is not there? Parathyroid is meant to A. It's lot of time questions are asked, so this is the answer. So it's a false. Then coming to the 20-year-old male patient presented with history of occasional palpitation, high BP, headache. The patient was diagnosed with pheochromocytoma. What will be preferred first investigation of choice? Pheochromocytoma we discussed earlier. Also, it is 24 hours urine metanephrine. So pheochromocytoma, what happens in pheochromocytoma? It's a rare tumor that causes the adrenal gland to produce too much of hormones epinephrine, adrenaline, and norepinephrine, noradrenaline. So epinephrine effects we know like this, and norepinephrine this. So control heart rate, blood pressure, and metabolism. Gain function. Effect on body triggers the body's fight or flight escape mechanism. This is epinephrine. E for escape, E for epinephrine. Norepinephrine trigger the body fight or flight response. Again, this both situation is like this. So in this case, what happens? These hormone increases and different symptoms are produced. So, and along with this, pheochromocytoma shows paragangliomas in thorax, abdomen, and pelvis. So this is the image of pheochromocytoma. Image can be asked sometime. So investigation: 24 hours urine sample for catecholamine and their metabolites, plasma metanephrine levels, and remaining you have to read this. Then pheochromocytoma or paragangliomas. Epinephrine, norepinephrine is generally sweating, tremor, nervousness, anxiety, weakness, paleness, visual problem, flushing. Mass effect, that is pain, surrounding structure dysfunction. Metabolic, that is hyperglycemia, diabetes, and weight loss. So cardiovascular symptoms, that is palpitation, hypertension, or orthostatic hypotension, dizziness, then gastrointestinal nausea, vomiting, constipation. So in this case, we have seen the symptoms: palpitation, high BP, headache. Then preferred investigation is 24 hours metanephrine. So this question is also asked previously. So 56-year-old presents with fever, chill, cold, fever, chills, cough with sputum. Blood pressure is 150 by 80 mmHg. Pulse rate is 18. SpO2 88. At X-ray done and shown. What is the probable diagnosis? So in this case, you should differentiate between pleural effusion versus one more thing, that is pneumonia, that is community acquired pneumonia. Pleural effusion. So what is pleural effusion? In case of pleural effusion, occurs due to increased hydrostatic pressure or low plasma oncotic pressure. So it happens in CHF, cirrhosis, nephrotic syndrome, pulmonary embolism, and hypoalbuminemia. So here in pleural space, fluid accumulates. Pleural effusion, it can be transudative and exudative. So this is transudative, this is exudative. In exudative occurs due to inflammation and increased capillary permeability. So pneumonia, cancer, TB, viral infection, pulmonary embolism, autoimmune, high protein and low LDH in this case. So here protein is low and LDH, low protein and low and LDH, low in protein and LDH. Here high stuff, high protein and LDH. So in typical community acquired pneumonia, what happens? Acute infection of lung parenchyma acquired outside the hospital. We know basic definition. Apart from this, most common cause, it's streptococcus pneumonia. So there will be bronchial breath sounds and crackles on auscultation, fever, cough, sputum production, rigors, pleuritic chest pain, dyspnea, tachycardia. Special findings due to low Burke constellation include egophony, then whispered sounds will be there. So if patient says 99, then there will be problem in saying that, and there will be whispering 99 like that. So in this case, what is the answer? So it doesn't look like pleural effusion for sure, because there is no whiting out of lungs. In pleural effusion there is white out lungs. In this case it must be pneumonia, since there are chills, fever, cough, and there should have been given like bilateral, what we say them bilateral, like on auscultation sound should have been given, and pleuritic chest pain, cough is given, fever is in this case it doesn't happen. So infiltrate. So community acquired pneumonia, this is cap. So you should know the x-rays for this too, and while revising radiology before exam you should differentiate these x-rays, because sometimes directly image is given and we have to comment on that, what's this, like pleural effusion or another like pneumonia. So inflammation of small and medium vessel, which of the following isn't part of classification? So this is important, you should know this classification. So large vessel vasculitis, medium vessel vasculitis, small vessel vasculitis. Large vessel vasculitis, we have granulomatous arteries in patient greater than 50 years old, giant cell arteritis. Then granulomatous artery in less than 50 years, Takayasu arteritis. Then medium vessel, we have necrotizing arteritis without MCLN syndrome, that is PAN. Then we have necrotizing arteritis with MCLN syndrome, Kawasaki disease. Is very important to diagnose or particular case. Now coming to small vessel, we have immune complex in vessels. Other sources for immune complex, like vasculitis. Then we have cryoglobulins in blood and vessels, that is cryoglobulinic vasculitis. Then IgA dominant Henoch-Schönlein purpura. Then SLE or rheumatoid arthritis, that is lupus or rheumatoid vasculitis. Then paucity of vascular immunoglobulin ANCA. In this case, we have three cases like microscopic polyangiitis, then we have Wegener's granulomatosis and Church-Strauss syndrome. So this is the question, which isn't part. So Church-Strauss it is, microscopic it is, and this, so SLE is not part. So this is the answer. Now coming to the next question, that is 45-year-old woman came with the complaint of fever, night sweat, generalized itching, and unintentional weight loss of 18% in last 3 months. On examination, she has enlarged cervical and axillary lymph nodes. The lymph node examination biopsy showed in the following picture. So what would be the likely diagnosis and treatment option? So in this case, there should have been given image. In this case, there will be Reed-Steinberg cell will be shown, and in that case that will be Hodgkin lymphoma for sure. So fever, night sweat, generalized itching, and these all weight loss denotes like Hodgkin lymphoma and axillary lymph node and cervical. These mainly involved in Hodgkin lymphoma. So treatment is ABVD regimen. So this is the symptoms of lymphoma: enlargement, shortness of breath, liver enlargement, nephrotic syndrome, bone marrow involvement, cancer cells. These are weight loss, loss of appetite, spleen enlargement, muscular weakness, and bone pain, joint pain and tenderness. So adriamycin, bleomycin, vinblastine, dacarbazine regimen is used, and these are the doses. Next question. So if 36-year-old man presents with high fever, bleeding gums, myalgia, and hepatosplenomegaly, TLC is 3,100. Hemoglobin 11, hematocrit 55%, platelets 25,000. What is the most important prognostic factor in this condition? So first we should diagnose what's this condition. So high fever, bleeding gums, myalgia, and hepatomegaly. TLC is this. Platelets are decreased. Hematocrit increase is yes. So platelets generally decrease, as well as high fever, bleeding gums, myalgia, that is body pain. 36-year-old male with hepatosplenomegaly, it denotes dengue fever. So in this case, what's the important prognostic factor? Always we tend to mark platelets, but it is wrong. It's hematocrit. This question is asked a lot of time. So this is the hematocrit prognostic factor for dengue. You should read this in detail at least once and then move on. So a young athlete presented with chest pain, dyspnea, his family history of sudden cardiac death. Currently he is diagnosed with HOCM, that is hypertrophic cardiomyopathy, obstructive cardiomyopathy. Harsh systolic murmur is heard left atrial border. Which of the following will increase murmur? Which of the following will increase the murmur? So which maneuver? So in this case, only one maneuver we know, that is Valsalva maneuver. Valsalva maneuver. So this is the Valsalva maneuver is performed. Sit down or lie on back, and then take deep breath. Third, while keeping mouth open and nose closed, forcefully push that breath out. Hold for 15 to 20 seconds, and then that time it can be felt, and it's performed in this case of CM, and murmur will be heard. A patient with bronchial asthma, 2 episodes in a day. First episode at night is prescribed albuterol to use as and when required. MDI FEV1 improved from 76 to 83 after taking bronchodilator. What's the further management plan? So in case of asthma, as per GINA 2023, steroid has a major role. From this, fluticasone and propionate 40 mg BD. This is major we will be adding. So this is GINA table. You should read it once. No need to go in details. Whatever the notes you have prepared, follow that, but just for proof purpose, here everything is given. So reliever is as needed, combination low dose ICS and formoterol is given. But in this case, fluticasone and propionate is the best choice. Next, now patient gives a history of epigastric pain radiating to the back since 5 days. Lab investigation shows amylase and lipase elevated 5 times normal in last 24 hours and 2 liters of saline was administered. He had a history of consumption of alcohol. So pancreatitis, and chest x-ray is shown like this. What's the complication? Chest x-ray. So chest x-ray gives us finding of respiratory distress, like these are the markings also here. So acute respiratory distress with pulmonary edema. This is edematous things are there, edema. So non-cardiogenic pulmonary edema or ARDS, it's a major. So here this question, pancreatitis is often linked to non-cardiogenic pulmonary edema and ARDS. So it can be asked in the form of one-liner as well as in this case format also. You should know the X-ray. This is edematous things are given, so you have to find like that. Now this is ARDS definition and ARDS slide. You can go through it once. What happens in ARDS, I will not be explaining because it will waste our time. Next, then we have a patient presented with difficulty in breathing that develops slowly and gets worse. Patient also has fatigue and leg swelling, edema. Internal jugular pressure was raised with rapid Y descent. Was diagnosis. So JVP abnormalities you should learn. So this is a table, very important. So and these are the corresponding disease, corresponding abnormalities. So in this case they have asked us rapid Y descent. So rapid Y descent has these, that is we have rapid Y descent, constructive pericarditis, severe right heart failure, tricuspid regurgitation and atrial septal defect. So among the options what we have, it's chronic constructive pericarditis, so CCP on rapid Y descents, and others like these marked in blue. These are asked many times. Large A wave, that is in this large A wave, pulmonic stenosis, Cannon A wave, atrioventricular dissociation, ventricular tachycardia, and large CV waves, that is constructive pericarditis again, as well as tricuspid regurgitation. So absent of Y descent, let's see in cardiac tamponade, one more question. So this can make 5 to 6 questions, and every year one question is asked from this. Now patient of COPD presented with ARDS symptom, what's the role of interleukin 8? So interleukin 8, basic simple one-liner, has only one role, that is recruitment of neutrophils, and this is the image. And recruitment of neutrophils, interleukin 8 does the recruitment of neutrophils. So this you should see once. So these are the neutrophils and recruitment is done by interleukin 8. Comes with so coming to 21st question, that is a lady comes with palpitation, dyspnea, bilateral crackles, irregular pulse. Which management is least useful? So you should first ECG, what ECG it is. So what we can see is there are small like fibrillation, F waves are there. So atrial fibrillation, palpitation, dyspnea, bilateral crackles, elude. So what is in atrial fibrillation? So which is least useful? So let's start with beta blockers. Rate control is used. Cardioversion if patient continues to be hemodynamically unstable. Yes, of course, cardioversion is done. Then titration of digoxin to improve ventricular rate in heart failure. Yes, digoxin is done. DOAC or warfarin should be started. Yes, but in this beta blockers for rate control, atrial fibrillation can turn into severe cause like as heart failure. So can convert into heart failure fastly. So beta blockers has no role or like least role here. So that's why beta blocker. But before that, congestive heart failure. So treatment options are these. So medication, diuretic, ACE inhibitors, ARBs, beta blocker. But these are later modification. But in this case, they wanted to ask like what are the major and like emergency treatment. In this case, beta blocker will be the least choice. So that's why we have done. And apart from that, these are atrial fibrillation algorithm you should learn. For avoiding stroke, you should give this dabigatran and vitamin K antagonist, warfarin, LA appendage exclusion, surgical imperativeness. That's different. Better symptoms. For symptoms, we give heart rate control, beta blockers, digoxin. But first is digoxin and later beta blockers. So among this, so recent question was that. So in this beta blocker for rate control, which is least. So this is now. Coming to next question. Child had a petechia, splenomegaly, lab investigation showed hemoglobin 7, WC count raised to 50k, platelet 60k, and long clinical stem. Was asked better treatment modality. So first child. So child, petechia, splenomegaly, 7 hemoglobin and greater than 50k. That's leukemia again. So ALL. In children's, generally ALL. So treatment regimen will be vincristine with prednisolone. Yes. So treatment with regimen containing prednisolone with vincristine. So most of the time this is used. Again, same. This table is very important. Age group. This will give us like clinchers, and this is the algorithm. In this case, vincristine with prednisolone. Corticosteroids. The major treatment. Remaining are not used. Now coming to this type, again a young child present with bleeding gums and bruising since, again young child, ALL. So bone marrow biopsy and flow cytometry were done. What's the diagnosis? So it's probably T phenotype. T type is common, and starry sky appearance on slide must have been given in this case, but from this you can't remember 100% that it's this. But this table, there is only one thing that's added: T cell ALL clinical feature, T cell ALL mediastinal. So in this, most common presentation is this. So you have to learn this. This type of MCQs will be asked with image, and little bit of less history was given. Like the major thing, they must have given starry appearance, whatever they're saying, starry sky appearance in bone marrow. This is not exactly they have given, but okay, T is the answer. So 28-year-old woman P1L1 came with complaint of weakness, fatigue, peripheral blood showed microcytosis, anemia. Her serum iron was low. She had increased RDW. Her MCV and MCH were also low, and TIBC was high. What would her serum transferrin saturation? So serum percentage they are asking. So we should, before that you should know this, that is transferrin saturation, that is serum iron by TIBC. So in this case, in our case, serum iron by, so percentage saturation multiplied by 100. So here serum iron is decreased, so of course serum saturation will also decrease. Simple. So it's reduced. So answer is reduced. What serum transferrin saturation level will be reduced. So this is the answer. And this table you should know differentiating these three type of anemias. Now the patient suffered from RTA. After a few days he had an exaggerated right-sided extensor plantar reflex and knee jerk. What other finding would have been seen? So RTA, exaggerated right extensor. So this case must be of Brown-Sequard syndrome. So Brown-Sequard syndrome. So what is Brown-Sequard syndrome? That is BSS is a rare neurological condition characterized by lesion in spinal cord which results in weakness or paralysis on one side of body and loss of sensation in the opposite side. So in this case, pain and temperature were lost in the right leg. No, pain and temperature, these sensation will be on opposite side. So this should be left leg. So this is false. Proprioception is lost in left leg, that is opposite. No, it's lost in ipsilateral, that is right leg. So this is false. Ankle clonus in the right foot, ankle clonus they are saying. So Babinski reflex in the ipsilateral side, yes, in the, so this is correct. Fasciculation in the right foot, no, false. Fasciculation is not. So this is the Brown-Sequard easy way. Once you read, you remember, like you can remember. So this is a major mnemonic. All sensory sensation would have been lost ipsilaterally. Dorsal column sensation, which are responsible for fine touch, vibration, 2-point discrimination, and proprioception, would be affected on the same side of lesion. Corticospinal tract, there would be an ipsilateral loss of moments. Ipsilateral loss of corticospinal tract, moments will be there. Spinothalamic tract, there are responsible for pain, temperature, and crude touch, would be affected on contralateral to the lesion. So it's easy. A lot of time is asked. You might my exam 2024 Jan, they have asked this question, and this time again it will repeat for sure, because every year sometime some way other round they ask this question. So this was recently asked in NEET 2024. So now a 40-year-old female patient is known case of myasthenia gravis on mycophenolate mofetil pyridostigmine now comes with breathing difficulties. Calcium level were 13.5 gram per dl. What is the most likely cause increase in this? So this question is related to paraneoplastic syndromes. So in this case, you should know a lot of stuff, like this table you should know. You should learn this table first. And so apart from this, so mostly myasthenia gravis is related to adenoma, that is parathyroid adenoma. Small cell carcinoma of lung, they also related, but most percentage is high in this case. So parathyroid adenoma. So these are the factual data. So you have to learn this for sure. In this, from this 5 to 6 MCQs can be made. So an exam, at least 1 to 2 question comes every time. So now patient present with dyspnea, chest pain, pleural protein by serum protein greater than 0.5 and pleural LDH by serum LDH greater than 0.4. What's the diagnosis? Before that, this is about pleural effusion. So this is criteria, Light's criteria. So you should know this. So greater than 0.5, greater than 0.6, greater than 2/3 of the upper limit normal, that is exudative type of pleural effusion. Transudative, in this case less than 0.5, less than 0.6. So in this case you should know these causes. In exudative there will be malignancy, tuberculosis, pancreatitis, collagen vascular disease, chylothorax, hemothorax. In causes in transudative there will be heart failure, major cirrhosis, nephrotic syndrome, and pulmonary embolism. So in our case it's greater, so it will be exudative type, and in this case tuberculosis will be answer, remaining will come under, that is transudative. Now Light's criteria done. Now patient came with complaint of flank pain, hematuria, weight loss, headache, nausea, convulsion, with families to a brain tumor and kidney tumor. MRI showed cerebellar mass. Diagnosis is a classic case of von Hippel-Lindau syndrome. So you should know about this. This is must be given. MRI finding will be given always. And apart from that, headache-like symptoms due to cerebral hemangioblastoma, retina, like eye pain will be there, like eye ache. Sac tumors can be there. Then adrenal pheochromocytoma condition can be attached to this case. Then pancreatic cyst or neuroendocrine tumor can be given, and renal cell carcinoma, epididymitis. Other this situation case can be made like way more different every time. So this is von Hippel-Lindau syndrome. Now decreased GFR, so decreased GFR is caused by, so before this you should know this, that is net filtration is equal to net filtration equal to glomerular blood hydrostatic pressure minus of capsular hydrostatic pressure plus of blood colloidal osmotic pressure is equal to 10 mmHg. So they are asking what will decrease in. So what will cause decrease? So decrease oncotic pressure. So decrease oncotic pressure. Let's see, decrease oncotic pressure. So if this oncotic pressure decreases, so it will increase. So GFR will increase. So increase glomerular hydrostatic pressure, decrease glomerular coefficient. So let's wait for this option. What's this? Increase glomerular hydrostatic pressure. If hydrostatic pressure decreases, then GFR will GFR. If hydrostatic pressure, so hydrostatic pressure, this is hydrostatic pressure, this. So if it decreases again, GFR will increase. And decrease Bowman hydrostatic pressure. If it decreases Bowman, then it will something is okay. Wait. So decrease this is glomerular blood hydrostatic pressure and decrease Bowman's hydrostatic pressure. Glomerular increase. Yes, increase glomerular hydrostatic pressure. Glomerular hydrostatic pressure increase, then it will increase. So it will increase. GFR will if it increase, then GFR will also increase. Decrease Bowman, it also increases GFR. So decrease glomerular coefficient will decrease GFR. So this is the rule out. By rule out method we can make this answer. So this is very important, can be asked. Then now, a 2-year-old male child presents with fever, hematuria, thrombocytopenia, history clincher, hematuria, diarrhea for last 3 days. Diarrhea will give towards pathogen. So what will isolate it from the stool? So firstly, thrombocytopenia, TTP can be. So HUS, Hemolytic Uremia Syndrome. In this case, E.coli will be the answer. So let's see. E.coli Shiga-like toxin is the virotoxin that will lead to symptoms. Triad, there will be microangiopathy, hemolytic anemia. First, triad symptom. Second, thrombocytopenia. Third, renal insufficiency. Epidemiology primarily affects children under age of 5. So clinical, there will be prodrome of abdominal pain, vomiting, bloody diarrhea, hemolytic anemia, thrombocytopenia, seizures, and lethargy. Acute kidney injury, triad will be the treatment, mainly supportive, no antibiotic, and eculizumab in severe CNS condition, plasma infusion, plasma exchange. So this question important. Now next question. Following beta-adrenergic blocker are useful in reduced ejection fraction, reducing mortality in CHF, congestive heart failure, chronic heart failure patient without any exacerbation for few years. So reduction. They are asking reduce mortality. So blockers, beta-adrenergic blocker that reduce mortality is bisoprolol. So this statement, bisoprolol significantly reduce cardiovascular mortality. This is related to pharma related MCQ. You should know this. Among these, bisoprolol is the main thing. So this was recent asked question again. A young man had a history of jaundice and raised HbS-Ag level year back. So this is given chart year back. They are asking one follow-up. He has normal level of liver enzyme. His current profile shown normal. Follow-up, he has normal level of enzymes. So seems case is resolved. What's the diagnosis for this current condition? So chronic hepatitis B with HbE negative? No. Chronic hepatitis B with HbE positive? Again, no. Resolved infection? It can be resolved infection because they are saying raise HbS-Ag level year back. So before a year. So after a year, we don't know the HbS level. It's like even if they are saying this, so most of the time we should tend to mark resolved infection. Acute hepatitis B, no. So for solving this question, you should know this data or each and every antibody, what they denotes, interpretation. Sometimes single liner can be asked, what does it mean, like that. And after that, you should know this table. In acute hepatitis B, there will be HbS-Ag positive, HbE positive, IgM positive in acute, IgG when it's positive then it's resolved, or resolved acute hepatitis B or seroconversion or low infectivity stage with anti-HBE, anti-HBS. Apart from that, chronic infections and high infectivity will be seen in HBsAg, HBeAg, and IgM negative and IgG positive. Now, HBV vaccination is in that case only one thing, that is anti-HBS will be positive. So this straight question. So whatever marked in bold letters are questions recently asked. So these are the tables. You should go through this, and these tables will be helpful for exam. Sometimes table will be in mind, and you can mark these questions directly by seeing like this. So this is the last slide. The two most powerful warriors are patience and time. That is Leo Tolstoy's quote. This is not question for sure, but this is a life question, like life lesson. So patience, guys. More 5 days, and I hope you all will pass, and good luck for FMG exam. So till that time, just keep patience. Do not revise like extra material. Just revise your old notes or whatever you have made for the last day. No need to go or change your track or change your source. So this you can watch for sure, because this is like very important. You can revise everything from this PDF. This PDF will be shared on my Telegram channel, Earthly Existence. So till that time, see you, good luck, and hope you all pass the exam.